Forward to the computer. I will not be standing here doing lectures in an empty classroom. Okay? Does that make sense? I'll be in my office doing lectures. I'm not going to stand here at the podium. Just not sure I would want to know that. So if you come wandering up here like, hey, maybe he's in there just talking to himself. No, I will be in my office. If I can, I have the elevator problem. So in my office, but there shouldn't be much elevator use if there's no students on campus after Thanksgiving, right? All right, so yes, I have you can hear it now. The humming of the elevator, that's really loud in my office if you didn't know that. Okay, let's get on. How was your first class? Was it good? Okay. Share my screen. Because we got hepatitis to go over today, plus other viruses, right? So we really spent a lot of time on virus immunology last time. I wanted to spend a lot of time with that. So are we here, hepatitis viruses?
I think so.
Slide 8? Okay, so you can see we didn't get too far. Okay, so yes, herpes simplex virus has an S in there, so it's not to be confused. Transmitted fecal oral route, we'll start there. Hepatitis A virus, hepatitis E, both are fecal oral of the hepatitis. Now, one of the things the book points out and the chapter points out, and I want to point out is that you can have hepatitis with other causes, okay? Hepatitis is inflammation of the liver. So it's, every time you hear, oh, they have hepatitis, don't associate that with, jump to these viruses immediately, okay? There's other reasons you can have hepatitis. So I want to make that point too, because that was one of the things that you get, it shocks you at the first when the doctor walks in, looks at your lab results and goes, oh, you got hepatitis, okay? So the patient's going to definitely go to these. What's it, B, C, or A? I heard all of them, had them in school, right? And it can be other reasons, that you have hepatitis. Hepatitis A, if you didn't know this already, that was it was the virus that probably got me this job. So the reason I'm here is because hepatitis A. If I hadn't told you that story, that was my interview presentation. When I came to interview for this position, I did hepatitis A outbreak in the region. So I did a little epidemiology presentation on the first case to the up-to-date case to a room full of faculty and students and deans and all that good stuff. So hepatitis A was here not too long ago. It was in the healthcare, it was in the restaurant workers. They were prepping your food, okay, and they were spreading it. So you had, I don't know if they had like one or two cooks that were going to all the different fast food restaurants around here, but it started up in Greene County. I think at, I don't know if I remember right, it was either the Double B's or Subway or somewhere up in there. And then it spread to Jonesboro, and then it was at Murdoch's, and it was at, just name a restaurant, pretty much had a case of it. What's that?
There's a lot of restaurants.
It was a lot. So we didn't know if they were, like, in my presentation, I talked about, well, is it all the restaurant workers living together, like in a dorm setting? Or are they just, all positive for Hep A? Or is it only one or two of the workers that were working days one place, nights at another? So fecal oral means that you are shedding it through the feces, you're pooping, and then you're not washing your hands and you're going and prepping food after that. So the signs that you see at all restaurants and all fast foods that say employees have to wash their hands after they come to the restroom before they go back to prep. The good thing right now with COVID is that we shouldn't see as much hepatitis A because everybody's washing their hands and putting on hand sanitizer, and we're more hand conscious right now. So maybe we see a decrease in other illnesses that we normally don't see. So those are our two fecal oral, so A and E, transmitted via parenteral route or through the skin, mucous membranes, and invasion. Okay, so these are the others, and we think of these as bloodborne, which means is that body fluids, blood, needle sticks, brings up your Hep B's, your D and C. So we hear most about right now, we hear most about Hep C. And we hear a lot about Hep C in healthcare because it doesn't have a vaccine for protection. And we'll get into that when we talk about vaccines coming up. But Hep B, we have a vaccine for it, and most of you are young enough that you took the series when you were born. It was part of your childhood immunizations, and you are now have had the vaccine for Hep B. Okay, so all of us in healthcare workers should have Hep B vaccine just for our own protection. So there's still chances of running into Hep B in healthcare, which means as you might have a patient that's Hep B positive. So how do these present? Laboratory findings, and how do they clinically present? General flu-like symptoms. With Hep A, it was diarrhea. Okay, so you go eat somewhere. I get messages all the time. You go out and eat and you immediately have diarrhea when you come back or the next day, and you want to blame it and say it must be food poisoning. Okay, Hep A does have a incubation period, and that was what's so hard about checking it and screening for it, or as we say now, contact tracing, right? You have a positive Hep A, and we need to know where you've been. And we'll talk about the window for Hep A in just a minute, but it's not an immediate. It's not like, oh, I ate it. Let's say I ate at Pizza Chef Saturday night, and I'm having diarrhea today, so it must be hepatitis A. Okay, it doesn't work. Now, food poisoning can do that, right? It can work pretty quick. Pain in the upper right quadrant of the abdomen, remember your anatomy, that's where your liver is, right? So if your liver is unhappy and it's inflamed, you will have pain from your liver. Hepatomegalia, and liver tenderness. Hepatomegalia, what is that? You A&P graduates, A&P 1 and 2 graduates. What is
it
the
enlargement of the
enlargement of the liver, right? So your liver likes to swell. Jaundice, always a good indicator that your liver's not happy. Dark urine, another good way of seeing it. And then light feces, which means is it light in weight or light in color? What does light feces mean here? L-I-G-H-T. Anybody? Light in feces, light feces.
The color.
Huh?
The color.
Color? Going with color? Okay. You want to go different?
Yeah.
You want to go with weight?
Yeah.
Yes, weight. And one thing, not to scare you or anything, but one of the things, we just lost our Jeopardy host this past weekend, is that pancreatic cancer. Also, you see your feces is floating a lot every time, and it doesn't have any weight. Okay, it's an unhappy feces. Okay, so meaning it has probably some fat in it, and that fat kind of keeps it afloat. But that's enough of the poop talk, right? Elevated bilirubin. Gosh, that's a lab test, right? Clinical chemistry. We're going to take our bilirubin, and that's total bili. Okay, and when you get to clinical chemistry, you're going to realize we have direct and indirect, and that makes total. So we do a lot of total bilis, but sometimes we're asked to do direct and indirect, especially when it comes to liver testing, and especially when it comes to jaundice, and especially it comes to newborn jaundice. And there's one that you can use hemolyzed specimens for. It does not affect But the other one, it does affect. You can't do a direct bili with hemolyzed blood. Liver enzyme, we have an enzyme that elevates, and that's our ALT. Specifically, there's other enzymes, but ALT is the key enzyme for liver. So you have liver tests. It's part of the CMP. It's part of the complete metabolic panel that we run on every single patient we run blood on. And it's part of the 14 individual tests, and it is part of the liver enzymes. So ALT is key to remember. I think that's a test question that pops up every time I've seen any talk about hepatitis. So let's take our hepatitis A virus. And one of the things that we need to know, and we'll go back over viruses next semester in parasite virology / course name. I hadn't changed the course name yet, but that's what it really is. We spend a good portion of the class in parasite, about halfway through we switch over to virology. So we'll bring all these back and give a good discussion. But with Hep A, the thing you need to remember, it has a very unique name, a class, a family name. And does anybody see it? Starts with a P. I don't think I have it on the slide. No, I don't. It's not on the slide. Does anybody see the name?
It's like Picornaviridae or something.
Picornaviridae. Very good pronunciation. Right? But that's not really the meaning. Okay? I like the pronunciation, but it can be confusing. So we can simplify it. Okay? So the easy thing to remember about Hep A, and this is part of my presentation, and I think I got Mr. Payne to giggle at this comment, was I took, what was it again, Allison?
Picornaviridae?
Picornaviridae, right? That sounds very scientific, right?
Sure.
So take it apart. Pico. What's pico? Pico in Spanish? Is it Spanish? Pico? Am I thinking I'm wrong? Pico? Small? You ever heard pico is small? Evidently not.
I thought you were talking about like the thing you get in Mexican restaurants.
You like the sauce?
The pico stuff. I was like,
Pico. Is pico small? Pico?
No, it's
P-I-C-O?
pequeño, yeah.
Huh?
It's pequeño, yeah.
Pequeño?
Pequeños.
Can you spell it with P-I-C? Can you say pico?
No, it's Q.
It's Q? Oh, it's Q. Pico. I was thinking it was pico small. Pico. Anyway, I thought it was a good little thing. The next thing you see is RNA. Okay, so RNA virus. So I put it together as small RNA virus.
Pico is 10 to the -12, so it is small.
Oh, it
If
is
you're
small.
talking chemistry-wise.
Oh,
it's
you
10
had to
the
get
12.
really complicated with me now.
Yeah.
Oh, pico.
Sorta.
That's one of those milli
Yeah.
going that way, right? Oh man, no wonder Mr. Payne laughed at me at that comment. Yeah, now it makes all the sense in the world, right? Anyway, that's the way I remember it. Okay, very small RNA virus, Viridae. Is Viridae a color? Is that Spanish for something else? Is that virus? Huh?
The green.
For green, right? See, I'm really off with my. See, I shouldn't even brought that up, I guess. No, I can't. I'm surprised I didn't get. I'm surprised I got the job. RNA virus, transmitted fecal oral. I think we have that down. Close person-to-person contact also. So you don't have to say you prep the food. So I said, well, if we lived in a dorm setting, in a room and we weren't very tidy and we, left a lot of stuff around and we really left a lot of our personal things around and fluids around and messy bathroom around, and could be a problem, right? Or we can ingest it. So that's how, healthcare worker preps your food, you eat the food, you've ingested the RNA virus, and you now have hepatitis A. Produces acute hepatitis in the majority of adults, but in children it's usually asymptomatic. So mom and dad are sick, but Happy Meal McDonald's, I'm all right. Formalin can inactivate, or you have a formalin inactivated hepatitis A vaccine. So there was a vaccine. How many of you had the Hep A vaccine? Okay. Did you get it when it broke out in around the area?
I got mine because I went on a mission trip out of the country.
Mission trip out of the country. Yes, good thing to do. Anybody else? How many were there? Let's see.
I
your
just
hand.
got it for school.
Huh?
I just got it for school.
You just got it for school? How many of you have had it? Let's see the hands again. Oh, we have had it? Are you ready? Did you really have it, or are you just raising your hand?
I got it when I was little for school.
Got it for school.
I don't know.
You don't
My
know?
mom just let me get shots.
Mom, so probably.
Yeah.
Okay. But there was a big push at the time. I guess this was back, gosh, when was that? I interviewed 2 years ago about this time. So
It was 18.
it would have been, 2018, Hep A. But yeah, so there's a vaccine for protection, right? Is it a good vaccine? Does it say? Administration of the Hep A vaccine or injections of immunoglobulin are recommended. The vaccine is preferred treatment for persons 1 to 40, but intramuscular injections of immunoglobulin, a sterile prep for pooled human plasma, contains the antibody, can be used to prevent infection of individuals of any age. To be effective, these treatments must be administered within 2 weeks of exposure. Okay, keep that in mind. So hepatitis A immune globulin recommended if unimmunized persons are exposed. So acute infection, IgM, right? And immunity indicated by total anti-HAV along with an IgM negative HAV. So that would be what? IgG, right? In other words. Okay, so they didn't really give us, I guess they don't really care what if we know the incubation time or not. But I know I read it.
Says 28 days.
28 days. Okay.
414.
28 days. When did we say that vaccine was effective?
Before 2
Before 2 weeks.
Yeah.
Yeah. So you got a chance, right? Got a chance to get that vaccine before hepatitis A rears up. So 28-day incubation. E, how many of you have heard of E before? Anybody heard of hepatitis E? No? Again, this is not very American. Okay, it's not American, but we just heard Preston say he went off on a mission trip. And I also need to tell you that Mexico is on the list with E. So it is one transmitted primarily through the ingestion of feces contaminated drinking water. So again, and I don't know if there is there a vaccine for E? I don't know. It doesn't say. Very self-limiting, asymptomatic, probably not. It's also transmitted, there's 4 types, genotypes. 1 and 2 are drinking water. 3 and 4 are infected pork or undercooked pork. Okay, so definitely want your pork cooked when you go out. So you see, including parts of Africa, Asia, Middle East, and Mexico. Outbreaks commonly occur after a natural disaster where what? The sewage water infects the drinking water, and you might not have a boil order in some places. So definitely is severe with pregnant women and immunocompromised persons. Acute infection indicated by IgM. IgG indicates past exposure. Can detect E virus RNA in the blood and stool samples during acute infection. So we can do that.
So it says that there is a vaccine.
There is a vaccine. Good, thank you.
License for use in China.
licensed in use in China. Why would China want a vaccine? We don't have any China students in immunology, so does it?
Well, it says it's for HEV1.
Okay. Is it any risk involved? Is that? It's been licensed for use in China. It uses virus-like particles that have been genetically modified to express a gene that codes for an HEV protein. Okay. We'll get into this a little later when we get into vaccines. It can be easily cultured. Diagnosis relies on serological and detect antibodies for the virus. Antibodies are typically identified with enzyme immunoassays that use recombinant and synthetic HEV antigens. So we have some rapid tests for E. Have you ever been tested for E? Probably not. Okay. So now that moves us to our big ones. So we'll spend some time here. This is B. Hepatitis B is a DNA virus. Okay, so different from A and E, those are RNA viruses, right? And you have a big chart in your book that shows all of these on page 412 and 413. If you want a summary of what we're talking about, it's a pretty good summary. So Hep B is the only DNA one of the group. That's one thing you can remember, hopefully, sticks out. So we see DNA viruses transmitted through parenteral or perinatal route. So sexual contact, IV drug use, occupational needle stick, and during the birthing process. So if mom has it, you could expose the baby during birth. So for us in healthcare, we're concerned about the needle stick. Hep B is part of the needle stick profile that we're asked to do. And just so you know, we have to ask permission of the patient to test the patient's blood for all of these if we get a needle stick. The scary thing is to get an unknown needle stick, okay, where you don't know where that needle came from. And that can happen in a sharps container. It used to happen a lot with butterfly needles. If you hadn't used a butterfly needle, you used to call those the snakes, because if you took them off and went to put them in the sharps container, they may find a way to come flop back out of that and stab you before they go under. They're almost like a snake with their head cut off. Luckily now with OSHA, we've come up with safety devices, and I leave you with this on that is please do never ever throw a needle away in a sharps container without engaging the safety device. They're there, use them, okay? And so many will say, oh, I'm putting it in the sharps, why should I engage the safety device? And please do that. So they're there. IV drug use, you know, that's gone away, right? Nobody's using IV drugs these days, all right? So there's no sharing of needles anymore, right? No. There is then, right? Yes. So if you haven't encountered a IV drug user in the ER at your facility or as a phlebotomist or anything else, trust them. They will probably tell you what they have. They will tell you. They will say, just let you know I'm Hep B positive. Just let you know I'm Hep C positive. Just let you know I'm HIV positive. Most of mine have been forthcoming if they know their results. They know their status. One of the things they will also let you know is if you're going to waste your time looking for veins, they will probably have a good vein for you they can point out. That's another good thing, okay? But it is still ERs we will find IV drug use. Sexual contact, you know, there's still that too, I guess, I would say. If you don't know your partner, there's no illegal sex not trafficking, but there's no illegal prostitution anymore, right? That's all gone away too, right? There's no way you could call a prostitute. You probably couldn't go to Vegas and go to a brothel anymore, right? That's all gone, right? Just throwing things out there, but I know that's all in the past, and we've moved past all of that, so no need to worry about Hep B. Or is Oh, and we're childhood vaccinating most people too, so everybody got their childhood vaccination with Hep B, so there's really no.
Sensing a lot of sarcasm.
Are you sensing a lot? Just a little? It's kind of my post-election rant, I guess. Acute infection, symptoms increase with age. So you're going to have an acute, but more chronic is what we're looking at. Persist for 6 months or more. Chronic infection occurs in 90% of the infected infants, 10% of the infected adults. So acute, guess what? You get it, you get over it, right? And a lot of people think since we have a vaccine, I always throw this out for virology, is that which one's worse? B or C? Which one would you rather have over the other one? I know you'd rather not have either one. But which one, if you had a choice, and you had to get one of these, which one would you go with? B? But we got a vaccine, so it must be worse. Okay. Don't fall for just because there's a vaccine that it's worse. Infection is preventable by immunization. Yay. We can also have immunoglobulin recommended for unimmunized persons exposed. So, what should you do if you get a needle stick? What do we always tell the students if you're out on clinical and you get a needle stick? We always say to tell them this. We always say consult with your physician. Go get your physician on board with what you should do. If your physician wants to give you an immunoglobulin, let them give you an immunoglobulin if your Hep B is undeterminable. You hadn't been vaccinated against it. So the reason I told about the patient getting their results is that's very important to us because I would like to know, right? If I can track the patient and find out what they do have, then that takes a lot of the unknown stress out of my needle stick. Still stressful, okay? And it's still gonna bother the person until they know, okay? But it's so much nicer to go ahead and check the patient, clear them for all of the things we're worried about. And that way our monitoring for over a year won't be as stressful because you have to monitor yourself for a year after a needle stick. Okay, it's an immediate test. They want to draw your blood, see if you have anything currently. They'll come back in 6 weeks, I think, 6 months and a year. So I think they're asking you to do that. Hopefully they'll pay for all the testing. They should. If you work someplace that's nice. And then we always want to try to check the patient. And a lot of these, have moved in-house, so we can do these testing. It's not something we have to send out as much as it used to be. So here is Hep B. So with Hep B, we have some serological markers. So far we know if we're going to check somebody for hepatitis A, right, we would do an enzyme immunoassay looking for what? The antigen of the virus of A. We put the antibodies on a test strip, put it in the wells, and we check for that virus itself. Okay. With B has certain things that we have to order, and I say this in ordering because you'll be the ones ordering these, because they'll just call you and say, we need a needle stick profile on Dr. B. Dr. B got stuck during surgery, and we've got to do a profile on the patient and him or her. Okay. So the surface antigen of B is a protein on the outer envelope. Excess circulates in virus-like particles in blood, and it's a marker for an active HBV infection, component of hepatitis B vaccine. And that's okay, we know that's part of the vaccine. But the surface antigen is what we are really, really worried if we catch that in the patient, okay? We really worry if we catch it in you after one needle stick, okay? Just so you do know, it can happen. I had a colleague gets stuck herself doing blood gases on a patient. Patient was 80 years old. 80 years old. Needle stick, like, she's 80. You know, it'll be okay, all right? We always, it'll be fine, no problem. 80-year-old patient comes back positive, Hep C. Right? And it was almost an immediate transfer to the healthcare worker. She tested positive too after a needle stick. Okay, so it was really, really quick transfer. Really, really quick. Okay. So don't just think they're 80, they wouldn't have anything. Or this is a grandmother. What, she wouldn't have any of this, right? Don't let that work your way into your thinking. You want to think of it like what? Everybody has every one of these. You have to treat it that way. Keeps you sane, it keeps you safe, and it doesn't let you put your guard down when you're sticking somebody. Hepatitis B antigen. Okay, so protein in the core of the hepatitis B virus, it is a marker of active viral replication and indicates the high degree of infectivity. So this makes sense, right? We're thinking about circulating virus particles to the surface is the first, and then it would have to be actively replicating for us to get the E, because that's a core antigen. And we took the virus apart in the first lecture on Friday. So those are our antigens. So now we look at our antibodies. So this will be what we're looking at. If you look down at the last one, this is what indicates immunity. Once you've had your vaccines, your 3-shot series, you should have an anti-HBs, surface antibody, okay? And what that is that outer coat antigen, right? We did it right here. Oops. Here's the outer coat surface antigen. That is your antibody, right? And it just said component of the hepatitis B vaccine is what we put in. Why do we want that? Why do we want our antibodies lined up to hit the surface antigen? It's the way it's going to present to the body when it's injected from a needle stick. That first antigen, you want antibodies geared up, right? To see that and to attack that and to bind to it and get the immune system on it before it has a chance to do what? Invade the cell, start replicating. Okay, so the surface antibody, if you have to, and you will be asked to run this on who? The healthcare worker. You always want to make sure you put that in there, because that's the way you say, you had your vaccine and you have antibody to the surface antigen of hepatitis B, so we're good there if the patient tests positive for it. That's your protection. So that's part of it. So you want to make sure you know how to test for that. You also want to do a core antibody. Okay, so you're going to do directed against hepatitis B core antigen. And if you have an IgM to the core, that indicates a current or recent infection, acute infection, and it detects the core window. And we'll get more into the core windows next semester, but we're going to have a chart here in a minute, or a graph that shows us all these. And then you have a total core antibody, consists mainly of IgG and can indicate a current or past infection. So you're gonna order anti-hepatitis B core antibody, and then you have anti-hepatitis BE directed against the E antigen, and it indicates recovery from hepatitis B. So we're not really wanting that one, right, at the beginning, because we're not worried about the E antibody this time. But later we want to say that, hey, they produced that E antibody, and that'll keep them from going into a chronic infection. They'll stay current, get over it, get well, and not move into the current chronic. So here is our typical markers in acute infection. So when you run your patient, when you run your victim of the needle stick, that would be us, right? as a healthcare worker, hopefully you don't find anything surprising on the victim, but you might. You might find out that they already had it, or they currently have it. That's never good. That surprises the victim of the needle stick, and they're unaware that they were already hepatitis C. And that's the big thing with hepatitis C is we say what? People go around and don't know they have it, right? We had billboards put up that said, please go get tested for hepatitis C. You may have it and not know it. But for B, let's look at, we got an 8 to 13 week incubation. It's not going to be right away. So as you see, immediate, 6 weeks later, 6 months later, and a full year after the needle stick, because we're looking at the window. We've got a window of almost, 13 weeks? Almost a whole semester, right? And then you start to see acute infection can occur 2 weeks to 3 months. So you start to get the surface antigen coming up. You get the E antigen coming up. Okay, got those two rising. And then they're going to drop down. So they drop down, and then from 3 months to 6 months, as we're moving through the symptoms, then you start to see total antibody for core coming up. You see IgM for current infection come up and go down. You see that we got anti-B E antibody and anti-B surface antibody. So you won't get a surface antibody peaked, for 4 months after infection, and then full recovery takes greater than 6 months to a year. So you get responses, you get your antibodies up, and this shouldn't be any surprise to you, this pattern, because you've been well aware of what goes on early and late. But just look at the time. It's a long time before those antibodies come up. So typical results, the healthcare worker is negative for everything except the Hep B surface antibody. You want the patient to be negative for everything except for the surface antibody, right? You hope they have a surface antibody too, that they got the vaccine for B. And then we have others we got to play with too. But that's a story that we want to make sure we go with. Typical markers for chronic HPV. Now this is going, right, we said it'd be an acute infection and recovery. The chronic infection, look, now you see symptoms go past that 2 to 3 month period into 6 months, into greater than 6 months to a year. And that's the chronic, that's the symptoms. And look at those antigens. Those antigens stay high through the whole time. Surface antigen and the E antigen. The antibodies come and go just like always, okay? But those antigens are still detectable out to a year. Compared to this, they drop off after 3 months. So that's when you got to worry. That's when you got liver damage. That's when you're going to have issues with B, okay? You didn't get recovered. So this looks very familiar. Serological testing for hepatitis B vaccine, or virus, sorry, not a vaccine, the virus. So as you see, here's the antigen part of the virus. Here's our antibodies. This is our ELISA testing. You see that both antibodies detect the antigen, okay? All right, did we run out of time? We did, didn't we? All right, we'll stop at D. And we'll come back and continue into chapter 23. Maybe we'll get going a little. I think it's a good pace, but all right. So we're going to end the Zoom meeting. Stop the share. End Zoom.